Our technical difficulties. Anyway, it's a pleasure to welcome Reshmi Patel, who's going to tell us all about predictive response to chemoradiation.
Do I need to switch it for the Zoom? Is it okay on Zoom?
Yes.
Right.
Is anyone on Zoom? Yes. Does it look good? Yeah. Okay.
Okay, great. Thank you so much. So our goal here is to predict response to chemoradiation therapy for cervical cancer patients. We're using a mathematical model, and we are calibrating that model to MRI data. So we've had prior success with a similar framework in breast, brain, and prostate cancer. And now we're trying to extend the same framework to cervical cancer for patients who receive both chemo and radiation. The overall structure of what I'm going to talk about and also our mathematical framework is we start with some image processing, then we calibrate our model, and finally we're able to make a prediction with that calibrated model. All right, so a little bit of clinical background to start. So when patients receive an MRI to determine their disease stage, they're considered advanced if they have a tumor depth of greater than 5 millimeters and do not have any distant metastases. So all the patients in our cohort here were locally advanced cervical cancer patients. And then these patients received concurrent cisplatin-based chemotherapy and external beam radiation therapy. So those treatments are what we are trying to model response to. Importantly, only 60 to 70% of these cervical cancer patients achieve a 5-year disease-free survival after the standard of care treatment. So there's clearly still room to improve these outcomes. And to be able to optimize treatment and improve outcomes on a patient-specific basis, we have to first be able to predict the response to these treatments. Okay, so a little bit on our framework. We have 10 patients from this data set, and they received both chemo and radiation therapy. We have a pre-treatment MRI scan, and then an MRI scan with the same data, which I'll show in a future slide, 2 weeks into treatment, and then 5 weeks into treatment. So what we're doing here is we are using the visit 1 and visit 2 data to calibrate our model, as well as the treatment schedule in between those 2 visits. And then we're predicting tumor status for each individual patient at visit 3. All right, so a little bit about the image processing that we need to do to get to our modeling step. The raw data that we have, first we have diffusion-weighted MRI at 4 different p-values, and we also have an apparent diffusion coefficient map that comes from that diffusion MRI. We have the DC, so dynamic contrast enhanced MRI, a pre-contrast scan, and then a set of post-contrast scans that were 10 seconds apart. So just to orient you here a little bit, on the right, you're looking at the patient's back. You can see their spine, and then on the left here is the front. So you can see here the cervix is enlarged, or the uterus is enlarged because of this really large tumor here. So we also have a T2 weighted MRI where we have a radiologist drawn tumor RI and also uterus. So we do have to take a couple of registration steps to get all of our data onto the same field of view and also align to one another before we can do our. So first, we just align the field of views between these 3 different types of MRI. And then we do a rigid registration to register the diffusion weighted and the DC MRI to the T2 weighted MRI. And we do this at each visit. So once we have all the scans registered at each visit, we need to do some registration between visits. So that's our inter-visit registration. And what is happening here is we have a deformable registration because some of the surrounding tissue can move from visit to visit, right? The bladder is deformable, tissue in the abdomen is deformable, but then we're imposing a rigid penalty on the tumor RI so that we're not biasing our eventual prediction by making changes to the tumor that weren't true changes that occurred. So you can see that at the bottom, after registration, we see an improvement in the alignment. And then finally, we take our ADC map, that parent diffusion coefficient map that came from our diffusion weighted data, and we can use that to calculate the number of tumor cells at each visit and at each voxel, which is what is going to go into our model. Okay. So our model is a reaction diffusion partial differential equation. We are characterizing the change in the number of tumor cells at each voxel as a function of cell diffusion, cell proliferation. So this is just a logistic growth term. And then we have a response to chemotherapy term, which is an exponential decay term. And we also have a separate response to radiation therapy, which is in the form of the linear quadratic model. So here we have an instantaneous death when there's a hit of radiation therapy according to the linear quadratic model. The parameters that we're calibrating, and I'll talk a little bit about how we got here, but we are calibrating a local proliferation rate, so different at each voxel in the tumor. We are calibrating a global value for the radiation therapy single hit efficacy rate, and then we're also calibrating the chemotherapy efficacy rate. On the right here, we are fixing or calculating these assigned parameters. I just want to point out the radiation therapy double hit efficacy is fixed to scale to the radiation therapy single hit efficacy rate, because since they're in the same term here, we can't calibrate both of them. So we're fixing the ratio based on a literature value. And then same with the chemotherapy decay rate. Instead of fixing it to one value, we went ahead and modeled over a range of values. So there's some uncertainty that arises there. Before we finalize our model, since this is a new disease site, a new treatment, like we have both radiation and chemotherapy here, we wanted to figure out what our most parsimonious model is going to be that best fit the data while also balancing complexity. So the model that I described first was the model we started with, and then we built a model family by incrementally decreasing the complexity. So for example, we can remove this response to radiation therapy term and just capture the overall treatment as an exponential decay. And then alternatively, we can remove that exponential decay, and now the overall therapy is just captured as a linear quadratic term. So we did test all of these models, but before identifying the most parsimonious model, we did a sensitivity and identifiability analysis. So briefly, the sensitivity analysis is what kind of confirmed which parameters we wanted to fix, which parameters we wanted to calibrate. And you can see here that the model is most sensitive to our proliferation rate and our radiation therapy efficacy. We checked the identifiability by starting with some initial tumor. We ran the model forward, and then with that synthetic data and the initial data, we went ahead and calibrated. If we got the same parameters out of the calibration within allowable error as our known parameters, we consider the model identifiable. So here, the correlation coefficients between the true and the fit parameters are all above 0.7, and we're taking that to be allowable error for the purpose of identifiability. So now that we found that all of our models were identifiable, we used the Akaike information criterion to choose the most parsimonious model. And it turns out it was our model that explicitly accounts for both chemotherapy and radiation therapy. So all of the results I show will be using this model, which was nice because then we can see something about both chemotherapy and radiation therapy dynamics potentially. So the inputs to our model here, getting into the actual, we take in an individual patient's treatment schedule from visit 1 to visit 2. We take the drug distribution, which comes from the DCE MRI, and that's used for the chemotherapy component. And then we have our number of tumor cells at visit 1 is our initial condition, and we are calibrating to the tumor cells at visit 2. We calibrate our model using 11 Bergmark-Hart nonlinear least squares formulation. And then what we get out is two global parameters, both those efficacy rates, as well as our local proliferation map. So I'll start by showing results for two example patients here. We have a non-responder on the top and then a responder on the bottom. And here we can see that when you look at visit 2, the calibration did work as we expected it to, right? The model data in blue lines up well with the observed data in red. The error here is coming from that range of 6 decay values that I mentioned. So the low end of that is really the lowest chemotherapy decay, where if the drug is sticking around for that long, it really kills off the tumor entirely. But the median values in both of these cases, so top is cellularity, bottom is volume, the median at visit 3, so that's our prediction, is lining up pretty well with our observed data. We can look at this on a voxel-wise level as well. So on top, we have observed. On the bottom, we have our model data. And again, you can see that at visit 2, the calibration is working well, lines up nicely. And then at visit 3, our general size and position of the tumor is similar, but especially with the responder here, you can see that the observed tumor is much smaller and denser than the model tumor. And this is something that we've consistently seen, where there seems to be some sort of tissue compression happening that our model is not quite capturing. So definitely an avenue for future exploration. And then we see a very similar thing here, but just in 3D over all of our slices. Okay, so then looking for the entire cohort, on the left, we have the change in the predicted total tumor cellularity compared to the observed total tumor cellularity. And then on the right, we have the same thing for total tumor volume. And we're getting high correlation coefficients of 0.95 and 0.83 in these cases. The 0.83 is clearly a little bit lower, and that comes from not quite capturing the tissue compression I was talking about. We also have a local accuracy metric. So what we're looking at here is each of these distributions is for a patient and for all of the patient's voxels. So it's essentially the error between the observed and the observed and the model data on a voxel-wise basis, where we are showing the median and the interquartile range of this voxel distribution. So the median over all of the patients here is around 11%. So our local overall error is also pretty low. All right, just to recap, our overall goal was to predict radiation for these 10 patients using a mathematical model that we calibrated to our patient-specific MRI data. And we were able to make these predictions for this cohort with fairly high accuracy. This is clearly a small cohort, so in the future, we would want to test with more cervical cancer patients, but this does suggest that our general modeling framework can be extended to patients with any sort of solid tumor where they have the available MRI data and are treated with chemo or radiation. I'd like to end by thanking my lab, and thank you all for listening.
Thank you. Okay, one quick question that's down here.
Hi, thank you for the talk. I was wondering, how can you distinguish between tumor cells and healthy cells from the ADC maps? And also, how can you know the number of cells from the ADC maps and not working with the concentration of cells? So, because the number of cells would depend on how the cells deform into the box cells and how many cells can occupy that space.
Sure. So I will say those calculations are definitely an estimate, but we are using the tumor RI that came from the RI that the radiologist drew, and then we're saying everything inside that tumor RI is tumor. Of course, that isn't going to be true, but for the purpose of this model, that's our estimation. So we can see where the denser regions are on the ADC map. That's going to correspond to higher cellularity.
All right, thank you.
Okay, thanks a lot.